I'm sorry for the mind map.
No, but I like them, that's why.
I've got all of them for the whole of your lab.
Doctor, both names all together?
My first name.
Oh,
Okay, is this it? We said we're going to start at 4. Will everyone stay until 4:30? Even faculty's not here. I'll give them a few more minutes. I don't mean to scare anyone, but Professor Hussein Abulanein sent his slides. He's got 120 slides in his slide deck. We haven't seen the cases. We're going to do them all together. Gelen gelsin ben başlıyorum. Guys, we're going to start now. Sorry for interrupting your break. Great, that was the final announcement. We're going to start. We've got a lot to cover. A lot to cover. Hear us enough. Will I get a complaint if I walk around? I'm surprised why don't you ask the boss? I'm in from. Yeah, but I can't interact with anyone like that. Is this good? Here? All right. When you go. Great, we got faculty, that means we can start. Once faculty arrives on the podium, we will start. The divas always arrive late, that's fine.
Good.
the delegates is that when the question is asked, they don't hear, so we should repeat. Okay. If we try and...
Yeah, we'll do that. Fantastic. Good. Last session of the day. I know it's tiring. I was a bit shy to share my picture from 10, 12 years ago when I attended here as a side, because it's a picture we were dancing and doing karaoke or something. And at that time, obviously, they were taking us to a more fancy place to entertain ourselves. Unfortunately, with COVID, that's not quite possible now. You've gone through pediatric urology. And I found it quite funny that at some point, I think it was yourself saying that, oh, this is an easy case. Well, I was quite scared with what I was seeing there. It's not going to be like that this session. But that's the good news, the infection. We've got 4 cases to go through, just 4. I will need your help to go through them. So I noticed that it's pretty the same people answering questions, and that's fantastic. But I think we need more people. So let's break into groups. We're not going to pick on anyone. We've got group 1, the right side of me, and left group 2. So please, one person volunteer from a group to answer a question if needed. And since there's nothing right or wrong, we're going to do this together. It will be fine. Now that's the good part. The bad news is that we've got the slide deck from Prof. Abulanein, 120 slides to go through. And I don't know, none of us know them. We don't know.
We don't know what there's in those slides.
We don't know what's in the slides. He can't present. He's got a sore throat. Good luck. We'll do it. Cool. Fine. What do I have? What do I have? Yes. 56-year-old woman you've got presenting to A&E. And she's unwell. She's got rigors, sudden onset fever. She's got a bit of abdominal pain. And you're at home, you're not on site, you get a phone call from the junior doctor, and they're telling this is the story they're giving to you. Sorry, I already revealed the answer a bit. What do you want to know from them? Very, very easy. What do you want to know? Hemostability. Good. What do you want to know now? Done? This patient's good to go home. As you say that, send the patient home, you hear the junior doctor crying, freaking out. What's your name, sorry? Sorry? Furs, your name. Furs. First sent the patient home back, and now the doctor's screaming out. What do you want to know? The doctor is not willing to send the patient back home. Something is going on. There you go. That's what you need to know. Patient's got temperature, feeling unwell, abdominal pain. Just do the sepsis screen. Ask all of these. Respiration fine? We went through sepsis in the morning a bit. Look at the consciousness. Does this have a laser? Yes. Consciousness level. Do we remember saying something about dementia? Elderly patients, they come in with dementia, then it gets worse, but they can't express themselves. Those are the kind of patients that you can miss. And then the outcome is catastrophic. Fine, you do all of this, and you consider using the early warning score, which is what we use in the UK. I don't know. Does anyone know what the early warning score here is? No. Let me explain. Does anyone know what the SOFA score is? I'm not going to ask you to explain it. Just, does anyone know SOFA score? 1, 2, 3, 4, 5. Yes. Good. Everyone knows SOFA score. Sequential organ failure assessment looks into a number of physiological parameters. It requires an invasive test looking at all different organs and trying to assess if the patient is actually sick or not, or are they under risk of deteriorating. And based on that score, if it's greater than 2, you'll put them into treatment, start them on antibiotics. But it takes time to carry out that assessment. Early warning score is a different way of looking into assessing a patient, and it uses these items, which are non-invasive tests that you obtain a score at the end of it. If you go online and type early warning score calculator, it will give you the score, and if it's greater than 3, or if there's been a sudden onset of increase in 2 or more, it means that your patient is under risk of sepsis. Cool. So that's early warning score that we prefer to use. SOFA is fair, but it takes a lot of time, I said, in the morning. So you can't ask your junior doctor who's on the phone who's freaking out with this patient, still you don't know why he's freaking out, and you can't say that I want to know the early warning score of this patient. You need to go through these items also and understand what's going on. Fine. And there's this little paper here saying that actually the value of clinical judgment is quite important in detecting patients who are under risk of deteriorating due to sepsis. I would be very, very concerned, even if I have a junior doctor freaking out when they see a patient. My first thing probably will be to get out of bed, even if it's at 2 o'clock in the morning, and get a bit more information. And if the patient is unwell, go down and see them. Good. So we spoke about, now not always, even if you're using the SOFA score, not always you will be able to pick up what's going on. So elderly patient, diabetic, they're on beta blockers, their heart rate might not go up. It might be deceptive. You need to check the other signs we listed here. Then we spoke about risk factors today. So we spoke about think of sepsis, and you put all of those together with a new score or your SOFA score, risk factors, additional signs, and then you decide what you're going to do. Cool. And then you apply sepsis 6. Up until today, when we spoke about it, have you heard of sepsis 6 before? Do you know sepsis 6? Yes? No? There's a few nods. Some people don't know it. 3 in, 3 out. Oxygen, IV fluids, what else should go in? Antibiotics, what should come out? Lactate, very good. What else? Put a catheter in, get culture. These are your basics, get it. Otherwise, even if you miss one, down the road it gets wrong. And this, okay, if you want RCT level, like the cancer guys are talking about, you have RCT level data for that. Good. Now, freaking out doctor, you've got this scenario, you're on the phone, and that's your patient. Okay? Okay, you're not going to send that patient back home. Cool. What are we looking at the fingers? What am I looking for? Yes, cyanosis, that's good. Capillary refill time, which doesn't go into any scoring system. So if heart rate and all this still are fine, but your capillary refill time is longer than a couple of seconds, and despite the patient is well warmed, not a good sign. Good. Resuscitate the patient then. Can someone tell me how they resuscitate their sepsis patients from my right-hand side? Yes. Just tell me one thing. We said sepsis 6. One thing. What do you want to do in resuscitation? I'm not looking at you. You've done your job. Volunteer. I'm not looking at this side. It's your turn next question. No? You never resuscitated a sepsis patient? Yes, 500 milliliters of fluid in 15 minutes. Good. There you go. Do you want to give more fluids? How do you decide if you want to give more fluids? Yes, tell me. Urinary output. Good. What do you want it to be greater than? .5 milliliters per kilogram, so something like 30, 40 milliliters per hour, 50 milliliters. Underneath that, patient is going to AKI. Remember what we said in the morning? You want your patient to be pink, peeing. Remember, perfusing well. Nice. You want to give some oxygen to them. Don't give high oxygen if they have COPD. You're going to harm them. Don't give too much fluids. You're going to harm them. How are you going to measure more? Look, other than the urine output, if you want to give more fluids or not. Septic patient, intubated. Anything else you can do to measure the fluid? We've got a hand there. Electrolytes, good. Something else? Central venous pressure. Something else? That's very good. Be a bit more invasive. Bit more invasive. Don't go into the vein, go into the artery. Put arterial pressure. Check the arterial pressure. That's where you're going to get your best measurement of mean arterial pressure. So when you go into managing sepsis, we said it needs to be a multidisciplinary approach. Cool. Who does that include as a multidisciplinary? You need an ICU consultant with you, or a senior reg. You can't do this on your own, we said. Fine. But you can sound cool now, and you can go and say, okay, have you put an arterial line in? Have you considered putting an arterial line in? Not that you know what's going to happen, but just tell them. Good. Imaging. I already give the answer, but do you want to do imaging in this woman? You've seen her, you've seen the picture. Should we put her in a CT scan immediately? She won't fit, fair enough. Let's find a CT out, but that's fine, yeah. She won't fit. I take that. I wouldn't put her in the CT scan immediately. I want to give her all the sepsis 6, resuscitate, pop in the intubate, put her in ICU, see that she's stabilizing and see what's going on. After that, do your CT scan. And good luck. So, we said about the antibiotics. This patient, as you've seen, has got a perinephric fluid collection abscess, fluid loss into the third cavity, edema, unconscious, unwell, and you want to give them antibiotics. If anyone tells you, why do you want to give the antibiotics in the first hour, you can say that I've been to a course in Prague, they've been nagging on all day onto me, but I know if that I delay them more than an hour, patients are more likely to die. Although it's a small proportion of patients, especially those who are severely septic, those are the ones who benefit from early antibiotics. So this woman would benefit from early antibiotics. Is that cool? Very simple. I told you infection is easy. Good. What antibiotic do you want to give? Are you going to give one antibiotic? 3 antibiotics? I see some patients given like a cocktail of antibiotics. We're not bartenders, so we better not do that. So how do we select the number of antibiotics? Based on how bad the patient looks, or based on other things? Based on other things, which is the algorithms there. Don't know if you've got it on your slides, but it's simple. Think if they've got suspicion of multi-drug resistant bacteria, give them a double. If not, give them a single. Here's your choice, and it's on the EU guideline. Who has high risk of multi-drug resistant bacteria? That's your list. Previous interventions, patients with catheters, patients who've been into ICU, patients who have a nephrostomy, and those who have a long-term indwelling urethral catheter are the ones who are more likely to have multi-drug resistant bacteria as a cause of their sepsis. Good. Feels like it's going in. Hand up. Yes, please. Wait. I will run.
I don't know if there's good evidence for this, but I've learned, and I know in the Swedish infection medicine guidelines for sepsis, they say that if the patient is circulatorily unstable, you should give an empirical broad-spectrum antibiotic, but you should also consider adding an aminoglycoside.
Is that based on their own data? Okay, if it's based on their own data, I agree. I see no harm until you receive the culture results. In a severely septic patient, you can go with double antibiotics, that's correct. Usually, looking at all audit data, most people, that's what they would do. They will give 2 antibiotics. Let me rephrase that bit again. I don't want anyone going out from here and giving 5 antibiotics. Ciprofloxacin, temocillin, let's cover a bit of gram-positives, let's give a bit of ketoconazole to cover the candida. No, you can give 2. Give cefuroxime with gentamicin. That makes sense. That's a good combination. Go back. Look, you can take one of those and pop it on with one of those out there. Give Pip-Taz with an aminoglycoside or fluoroquinolones. That's fine. No one is going to judge you on that. But if it's mild sepsis, no. Cool. No, I don't, because of the European Medical Agency report that we should not be considering fluoroquinolones as upfront therapy. Neither do I go with fluoroquinolones as upfront therapy on its own. I would rather go with Pip-Taz and Gent. But again, if the patient was on Pip-Taz and Gent 2 weeks ago, then I would consider fluoroquinolones. Does that make sense? So a patient comes in septic. 2 weeks ago, they were on Pip-Taz and gentamicin for another infection. Then they progressed into sepsis. What would you give now? You can give anything else other than those 2 antibiotics they've been on, and not a beta-lactam, because if it's resistant to Pip-Taz, which is a broad-spectrum antibiotic, it's most likely that it's going to be resistant to all cephalosporins and penicillins. So you need to switch. And this is why what I said is important, MDT approach. You need infectious disease to help you. Yes, at 2 o'clock in the morning, there's no infectious disease that's going to help you, and you need to make the call. Cool. Patients now, we're at the stage where it's been resuscitated. She's intubated. She's on inotropes. Cultures have been taken. Well done, sepsis 6. We've given Kef plus Gent. Well done, my friend. Are you from Sweden? Referring to the Swedish audit. Lovely. You've got third space fluid loss. Here's your CT as a reminder. Okay? You're in a meeting now. I've been keep saying MDT, MDT. Here we go. Here's your MDT. And you've got the intensive care consultant telling you, you know what, she's not really responding well now. She's stabilized, but why don't you, you're a good surgeon, I heard of you. Why don't you just go in and take the kidney out and let's sort out the source. And what do guidelines tell us to do? Fix the source, fix it within the first 6 hours. Is the consultant here, the ICU consultant, wrong? Why?
I think in emergency settings, it's better to just drain like an abscess, so put a needle inside, and that would save her life.
And that's the beauty of urology. You put a catheter in, you put a stent in, you put a drain in. Good. Okay. So you choose the least assaultive approach to manage an infection, the source. Guidelines tell us that it needs to happen in the first 6 hours, to manage your patient. Good. I'm sorry for that, that's the old guideline. First 6 hours. Okay, if you do it up to 12 hours, no one is going to put you to court, but if you miss it beyond that, you're in trouble. Okay? So you put a drain in. Is that the decision then? We go for a drain? Nice. There you go. Put a drain in. That's what came out. Do you think this patient survived? Yeah? Who think that it's not my patient? It's not my patient. This is a case from the previous years from Professor Florian Wagenlechner, who I took over the lectures from. It's his case. It's his patient. Well, we moved on to the next case. No, unfortunately, no. It's hard for these patients to make it through. It's difficult. Cool. Sepsis done. That is sepsis. And we have a question from here, from the floor.
Thank you. Excuse me. What kind of drain did you put? She had also thoracic in the left hemithorax. It was complete fluid. So you should put the nephrostomy catheter for the collecting system. We would put also a nephrostomy catheter probably in the perinephric space and below catheter.
So do you think the fluid collection in the thorax is infected?
No, probably it's just from the third stage fluids, but
Yeah.
right now I think she needs to decompress.
True. So she's not ventilating well, probably due to that.
Yeah.
But the first, just to correct the drain, you don't need to actually put a nephrostomy in this patient. You need to put a decent large drain into the perirenal cavity. This is a perinephric abscess. You need to drain the abscess out. Which a drain, as I have not managed a patient, which I know it's not an excuse here, but I don't think a drain alone will sort out the business. It will buy you some time. Probably you will need to drain that thoracic fluid, but after treatment with adequate diuretics in a scenario like this, if I have been taking care of her, I would wait at least 12 to 24 hours to see if there's improvement. Repeat a bedside ultrasound to see if there's any change. And I wouldn't make the decision on my own to pop in a drain into the thorax. I'll talk to thoracic surgeons before that.
Thank you.
Because it's been probably 10 years before I've done that one. I would probably cause harm. But I agree. Yep, we've got another question.
If this patient make it through this episode with the drainage of the abscess and drainage of the kidney, and it's non-functional kidney, how long do you wait before doing the nephrectomy? 6-8 weeks?
Patient stabilized, you can wait. Patient and still having recurrent infections, I would say there's no evidence for that, zero. You just need to wait when things are settled down. If you go in early, you're going to cause bleeding. You can't do that nephrectomy early on.
Sometimes we have patients with such situation,
Yeah.
and we have the antibiogram.
Yeah.
They go out, they come we schedule something after 2 months, and
Yeah.
they come after 10 days with another episode, and then another episode, and then you have to wait, but you have to operate at some time.
Probably you shouldn't remove the drain before pus completely stops. You should keep them on long-term antibiotics, which I rarely say that, but you need to keep these patients on long-term antibiotics and take it from there. The earlier you do it, better for control of the source. Very early, in 2 weeks, the patient still has not recovered from their circulatory disorder. You're going to harm the patient like that.
And also intraoperatively, it would be difficult. There is like a...
So both surgery is difficult, but let's say you can sort it out. Still, the physiology of the patient will not be adequate. But if they're having sepsis and you can't control it, you have no other choice. You have to do it. Otherwise, they will die from sepsis. And that's a recurrent UTI then. That's a recurrent sepsis. Good. Next patient. This patient, I treated him at some stage, and I'll reveal which stage I've treated him. It's a recent case from London. Everything is true. Some numbers I played around with, that's all. So there you go, 56-year-old, PSA 4.2, GP seen them, no LUTs. They referred them for a prostate cancer screen, although we don't have a screening program. They said, okay, probably this is prostate cancer. Repeat the PSA for a second time, do a DRE, no suspicion, do an MRI, anterior horn, Likert 4 out of 5. Have you done your prostate cancer section yet? Good, you know what I'm talking about then. 4 out of 5, highly suspicious. Probably 70-75% chance of picking up a cancer, and a significant cancer probably, with a primary 4. So he agrees for a local anesthetic transperineal biopsy. Remember, I said leave truss biopsies. And would you do antibiotic prophylaxis? Left side? Yep, we've got 2 people already. Nice.
We usually give cephalosporin as a single shot dose for the transperineal biopsy.
Okay, is that your standard practice?
So standard practice.
Where do you work?
In Salzburg, Austria.
Excellent, thank you. And I think another colleague of mine there was.
We give third generation of cephalosporin, cefpodoxime.
Excellent, okay. Does anyone know if there's is there anyone else asking for it?
We use fosfomycin.
Fosfomycin, who's that? Can't see. Okay, thank you. Okay, fosfomycin. Where do you work?
In Zaragoza, Spain.
Nice, okay, all right. Sunny days. Fine. I've got bad news for you guys. There's not a single study showing what we should do. We don't know. So third generation cephalosporin is quite strong, I would say. We give Gent. But we give Gent, apparently, I learn, at the wrong dose. We give it at 120, our trust guidelines suggest. But we're starting a study, a trial, we're trying to power it, to say that actually you don't need to give antibiotic prophylaxis for transperineal biopsies. No? Does anyone buy that? Would you do a transperineal biopsy without antibiotics?
So that's actually what we do in our Dutch center.
Lovely.
Yeah.
Where do you work?
Rotterdam.
Nice. Thank you very much. Okay.
There's a hand over here.
Yeah.
Yeah, I was going to say exactly the same. We also don't give antibiotics for transperineal biopsies.
Fantastic.
And actually, I think there's a study, a meta-analysis, that showed there is no difference in infection rate.
If you have something controversial, say it then. Look, sounds cool. I like that. I prefer to do it without antibiotics, but look what's going to happen with antibiotics. So this is what they gave. Remember, our trust policy is to give 120. And we spoke about that. So the infection rate is much lower than a trust biopsy. Urosepsis rates are 0.1 in TP, 0.9 in transrectal biopsies. You do now and then hear about people dying from transrectal biopsies, and considering that it's a diagnostic procedure, it's a bit unacceptable, especially if you factor in the mortality of most of the cancers you're going to find, which are either 3+3 or 3+4. I would say think very, very carefully before subjecting someone for a biopsy. So if you haven't moved yet to TP, please do. And that's in the guidelines, both in the prostate cancer guidelines and infection guidelines. Fine, he's got his biopsy. I'll move quickly here. Benign, as you would have expected. This is an infection station we're talking about. He's fine. 2 weeks following his biopsy, this is what he presents with. Right testicular pain and swelling, no LUTs, no systemic symptoms. On examination, the testis is tender, epididymis is tender. There's no fluctuation, no hydrocele, no fluid collection. Skin is fine. I'll just move on. So the clinician seeing him suggested that get some Augmentin, get some painkillers, go home, take time off from work, relax, watch some Netflix, you'll be fine. Good. Would you have done anything different? I want to hear the controversial people. Would you have done anything different? Come on, the way the question is coming, you must have done something different. There's someone there. There is something to do different. There's plenty of hands.
I can't see hands.
Augmentin, someone is challenging Augmentin. Good. Augmentin is amoxicillin plus clavulanic acid, beta-lactamase inhibitor.
I would have get the patient in hospital.
You will admit the patient to hospital.
Yeah,
fine.
No anti-inflammatory.
You wouldn't give an anti-inflammatory?
No.
He's in pain?
No, just painkillers like paracetamol.
Fine, I buy that. That's good. Anything else? Urine culture, good. Wasn't done. We're going to pick up a lot of mistakes. Come on, be brave. You will do better when you see what's happening. You know you will do better.
I would have given other antibiotics.
What would you give?
Like maybe trimethoprim or...
It's fine. Yeah, trimethoprim is a good option here. Cipra is a good option because he has had his prophylaxis with Gent.
I would have done an ultrasound.
Lovely. What else would you do with that ultrasound? Is there anything else you specifically want to ask your radiologist?
Yes, I would like to see if there's an abscess.
Nice.
And I would like to see if the testicle has still blood perfusion.
Very good.
And I would like to see if there is a lot of residual volume after voiding.
Very good. Very good. Very good. You solved the case. Good. I think we covered good points there. So the patient now is on Augmentin, amoxicillin with BLI. 1 week later, he rocks up again. They do an ultrasound this time, thankfully. They see a bit of hydrocele. They asked if there's an abscess. There is no abscess. But unfortunately, they didn't look at the vascularity. Treatment at that point was switched on to Cipro, and he was discharged home. You need to understand, of course, we're in COVID times, we don't have beds also. So I don't think it's wrong to discharge the patient home, but there's a lot of mistakes here. Good. He rocks up again 4 days later, in severe pain this time. Admitted, ultrasound, again, no Doppler. But they now this time, comparison with the previous images, which was not done on the time, but in retrospect, in hindsight, we know that there was progression in that hydrocele, and now you could see echoic material inside, which is indicative of an abscess developing. Admitted to hospital, given IV KEF, repeated ultrasound, a repeat scan requested for the following morning. Good. So now we're in this state. This time the patient does not want to stay in hospital. Wants to go home. His grandmother apparently sadly passed away, and he wants to be at home to support his family. What are you going to say to your patient now? Go home? Difficult situation. Don't know. I don't know. Do you want to say something? Help me, because I'm looking into this.
Till now, I didn't see any laboratory results. No.
Okay, I mean, the blood tests, they were all done. I'm not, for the sake of time, I haven't shown them. CRP was done, sedimentation was done. Lactate, would you do lactate? It's not necessary. Lactate is to show perfusion, microvascular perfusion. You're not concerned, he's not septic. They did look at his residual urine. He was not retaining residual urine. From that aspect, white blood cells were elevated, but not in 20,000. They were around 14, 16 on top of my mind. So despite that advice, strong advice, patient goes back home. This time he switched back to ciprofloxacin. And then 6 weeks later, I'm on call. Can anyone guess what happened now?
He came back.
He did. And I'm on call. Fournier's gangrene, that's one option, yeah. That might have happened, good. What was Fournier's? What type? What type of infection is Fournier's? What type of necrotising fasciitis is it? Type 1. Polymicrobial.
Very good.
Good. Good. What else could have happened? This is what happened. Doc, I feel good, he said now. My pain is gone. Of course. Of course your pain is gone. Pus is coming out from the scrotum now. What do you want to do if you see this? You check if there's Fournier's, of course. Do you want to do anything else? What should have I done that night? It was like 10 o'clock and I just finished a major case. I'm very tired. What do you want me to do? Someone tell me what to do. I was tired. Don't do this to me. What are you going to say?
Apart from a whole workup, I think that he is a high risk of tuberculosis, maybe because of the auto-drainings of pus to the scrotum.
Okay.
But for sure, we have to do the whole workup again.
Is that now? It's 10 o'clock at night. He's got pus coming from his scrotum.
Culture of the pus.
Good.
Urine culture.
Yeah.
Ultrasound.
Okay.
For sure, all of the blood tests for the infection.
Good.
For sure, admit the patient and start again IV antibiotics. Double regimen. For sure for anaerobial bacteria.
Yes.
But I think that we also have to take cultures for tuberculosis, at least for the flora of where I come from.
I take your point for tuberculosis, and I promise I'll get back to that in 15 minutes, if that's okay with you. Do you want me to do anything else? I'm there. I'm standing there. This is real.
Would you give him IV antibiotics?
I gave him IV antibiotics.
He's doing well. He's not febrile, and he's
not
drained.
febrile. He's drained. Remember of the medical legal aspect of the whole case. Okay, I take him to theatre. I did hear a bit things about emergency surgery. Yes, I did do a Doppler scan on him. No vascularity, dead testis replaced with pus. Did an orchidectomy on him. Testis completely replaced with pus. Organ loss. And obviously he's going to sue us. Obviously, you need to go through the... I think there's a hand there. Sorry.
Sorry.
Before going to operation room, would you do a CT scan?
For?
In order to find out if there's any pus going from the scrotum up to the upper part?
Good point. But on palpation, his inguinal cord, I could feel it after a certain point. His abdomen was soft. You can't, I mean, I could access a CT scan. I don't think it would change my management. But no one would judge you for doing a CT scan at that point. Fine? Guess what he's going to win the case from?
There's a hand here.
There's a hand.
Do you think the ultrasound you did pre-operatively changed your plan? I wouldn't do it.
Why did I do it? I agree with you.
You go to theater and you can inspect scrotum as well.
Why did I do it? Yes. Medical legally, there's been deviation from standard of practice. You need to document everything very well. I agree, it's not going to change your management.
And do you think you missed a torsion, or is this a secondary infarction because of ongoing infection?
This is secondary to the infection. We don't know if it's due to infarction. We don't know if it's due to the increased pressure in the testis. We don't know if it was because the hydrocell got infected and destroyed the testis. We don't know how it came to that point. There's a lot. I just skipped through a lot of steps, of course, and I'm trying to make it a bit more dramatic. Some steps, of course. But a TP biopsy with antibiotic prophylaxis has led to epididymoorchitis. Just remember the morning lecture from epididymoorchitis. Think of other bacteria, think of other sources, get a Doppler scan, check the vascularity. If it's a primary case, you can get away without doing an ultrasound. But if it's a complicated case, get an ultrasound. Always think that it can. What's the percentage of epididymoorchitis leading to abscess? Exam
10 to
question.
20% maybe?
Sorry?
10 to 20% maybe?
That's quite high. It's between 1 to 5 max.
Okay. Did you check for STDs? Probably it has to do with the function.
Well, the bacteria that grew was Streptococcus hemolysis.
Okay.
In 3 different cultures. So the culture we took at the site, the culture we took from the specimen, and then the microbiologist told us also, talk to your microbiologist in these cases because they want each specimen in a different pot. I can't remember, but it's quite important. Cool. We covered prophylactic antibiotics, and now my last case. Do we have time? I'm sorry.
Yeah.
Thank you. Good. This is a case I presented 13 years ago at EAU, and as a nightmare case. At that time, I was working in Turkey. This case is from my training days. I wasn't primarily involved in its management, but I gathered the information. You've got a male, LUTS, not refractory to medical treatment, and he's got left testicular pain, left-sided testicular pain. Here you go, we've done his assessment, take a history, got the IPSS score. I'm sure everyone does that as part of LUTS assessment in their clinic, as well as listening to their symptoms, understanding what the most important symptom is to treat. And he's been on antibiotics for some reason, on ciprofloxacin, which I will pick up later. Good. He gets examined. This is the findings. Nothing special apart from a tender and firm right testicle. Okay? These are the blood tests, a summary of some things that we think that might be important. This is a summary of our patient. LUTS, refractory to treatment, left-sided testicular pain, detailed examination, looking at everything in detail. We do uroflowmetry, showing that there's a low Qmax. It's an intermittent flow, not interrupted, so it doesn't go down to 0. It's like a staccato flow. We've seen it a bit earlier today. And time to Qmax is delayed, but not massively delayed. These are things to think about your differential diagnosis. Post-void residual is elevated. What would be your differentials? Okay, it's an infection question, of course, but let's say you're in a FIBO, you're in your exam, and they ask you, what are your differentials?
Prostatic, maybe utricle with a reflux in the testicle via the ejaculatory duct.
Okay, good. And why would the urine reflux into the epididymis?
Usually it's a utricle or a patent ejaculatory duct.
It's something a bit more common, the utricle. He's 70 years old. If it was the utricle, you would expect that.
Stenosis, maybe.
Stenosis of
the urethra.
Urethral stricture. Yeah. First differential diagnosis. Good. That might explain the LUTS. Fair play. What about the testis, epididymis? Are you concerned? There you go. When you find a testicular mass, you need to think of testis tumor. He's got a mass in his testis also, palpable. Doesn't matter if it's an infection session. I'm not saying it's testis tumor, I don't know yet. Well, I do, but okay. We do a scrotal ultrasound, we check for his tumor markers, we do a flexi to check for the urethral stricture. Here is his ultrasound findings, and here is his tumor markers. For some reason, we checked for his STD, for syphilis and everything. Treponema pallidum. Does anyone know how you diagnose Treponema pallidum? Do you know the stages of it? Syphilis. Sorry? Primary, secondary, tertiary. Okay. Which stage do we see them? Primary, usually. Single focus ulcer on the glans penis. Painful, non-painful? Nice. How do you treat it when you find it? Nice, nice. Oh, God. I told you don't need this. Okay. Tumor markers, flexible cystoscopy confirms that there's a urethral stricture. My friend who said tuberculosis, we did a sequential urine analysis. We checked for the morning AFB. They were all negative for TBC. And this case was managed in 2005, guys. So today, in the guidelines, if you're concerned of TBC, this is what you need to do. Again, you do 3 sequential urine analysis, early morning, but you look at PCR. It's more specific, it's more sensitive, not more specific, more sensitive in picking it up. Good. He carried on, had an orchidectomy because they were quite concerned still of a tumor. They couldn't distinguish. They thought of TBC. They couldn't show it, but it was a necrotic chronic granulomatosis. Obviously had a urethrotomy also. His LUTs got better, and we confirm a diagnosis of TB.
Yes, he's 70 years old. It's not a common age to have a testicle tumor. So if we think about tumor, maybe we have to check again in search of maybe lymphoma, because it's the most common tumor at this age, maybe. Maybe CT scan, or does he have fever or adenopathy?
I don't know if they've done a CT scan on this patient at that point. It does make sense, because even if you're looking for TB, you need a chest X-ray. I assume it was done, because I have the results here, which are all clear. The abdominal CT scan, I don't know its sequence, to be honest with you. But it's a good point. Good. It was inguinal. Because I was quite junior, I wanted to operate. Okay. Okay. Business done. Finished case. Should we move on to trauma, or is there anything else we need to do for this patient? Radiotherapy.
Quadri therapy?
Sorry?
He has tuberculosis, right?
Yeah, yeah.
We do the pre-treatment exams.
All done, all clear.
Okay, and we treat him.
With?
Isoniazid, rifampicin, ethambutol, and pyrazinamide.
Good. Wow, I'm very impressed. Okay, one more question. If you give isoniazid, what should you give with it? What vitamin do you want to give? B6 pyridoxine. Good. Wow. I told you, you know it.
They're good. They're good.
Very, very good. That's the duration. That's the side effects for the purposes of your notes. Lovely question to ask on MCQs. I think it's useless to ask, but they ask it. This will take me 2 minutes. TB is uncommon. You don't need to know everything about it. No one knows everything about it. I'm quite impressed that you know the antibiotics. But you just need to know that it's somewhere in your mind. So just thinking of it is a good idea. You've got a 36-year-old woman with recurrent urinary tract infections. She has tried, for a long time she was on antibiotics. She switched on to behavioral modifications, so went back to the basics, gave her D-man nose. Number of infections got reduced. She has no infections for the past 16 months. But you must appreciate the fact that she's quite stressed, and she does random urine cultures. She comes to clinic with the results of a random urine culture like this. Left side is quiet. Does left side want to know anything? Pregnant? No.
Does she have diabetes? Badly controlled?
No. Something simpler.
Any symptoms?
Any symptoms? There you go. Ask the patient. She's asymptomatic with bacteria in the urine, which is called very good. Very good. No. Say it out loud. Say it out loud for us.
They all know it. So asymptomatic bacteriuria.
Fantastic. Even if it's asymptomatic bacteriuria, they still give you sensitivity susceptibility profile. Now, this is classified as a multi-drug resistant asymptomatic bacteriuria with a history of recurrent urinary tract infections that's been clear for 16 months. She wants us to prescribe her antibiotics, very good antibiotics, to eradicate this bacteria. Those who would give and try to eradicate, raise your hands, please. No one's going to eradicate this bacteria. It's multi-drug resistance. No bias? No? You're going to leave it like that? You're going to give me one good argument to send her back home without antibiotics. One good argument. If you're doing this, you need to know what you're doing. Why? Excuse me? She's imposing problems, so you send her to someone else.
No, I think he said...
Any problem? She's asymptomatic.
Okay, she's asymptomatic, but she wants antibiotics. It's MDR. What is your argument not to give her antibiotics? She's 36 years old. You need to say something very good to convince her. She's very intellectual, very well educated. You need to give her evidence. Please talk to the microphone.
You have to explain her that she has like a germ in the urine, but it's asymptomatic. It sticks to the bladder because there is like urothelium. It can't go into the systemic circulation.
She knows it all. I'll give you the answer. If you treat recurrent UTI asymptomatic bacteriuria, you make it worse. Because remember microbiome from this morning. You're changing the diversity. From a wide, diverse population, you're reducing that population. You're making it worse for her. Don't treat asymptomatic bacteriuria unless there's these three conditions. And the word is not to treat, you're eradicating because there's no symptoms. So this is your answer. Madame, if I give you antibiotics, you're going to get worse. Good. The European Society of Infections have published about this. I can find the paper and give it to you. Done. I will just skip all of this, which is the same. Thank you.
So, should we take a couple of trauma cases? We haven't seen them. We can work them together. Shall we do that? We have no idea what there's installed for us.
Okay. Yeah. I can still deal with some. Do you want to did you put them up?
It's not this one. It's one of the ones we gave you. The last one. Trauma, yeah. It's PowerPoint.
We're not bluffing, we really don't know the cases. It's not a game. Now you all feel comfortable. We don't know also what we're talking about after this.
Okay, case one. Can we have next slide, please?
I got it. Okay.
You got it, okay.
Apparently all are real cases.
All are real cases, okay.
Oops, okay. Okay, thanks to Professor Abul Anain, who couldn't visit us from Egypt. I'm trying to skip, but it's not working.
Can
I
you
can't get this
Can
working.
you skip to the next slide? Let's see. Okay. Are there only 3 slides? 120, okay.
Don't be optimistic, that's not it. Do you have an...
from last one.
Did you open the video or the cases?
Cases.
Just click the arrow to see if it changes. Do you have the flash?
Yeah.
Does it change from the keyboard? There's 120.
Or we can put it to other.
Bear with us for a couple of minutes, please.
Now we are okay.
Lovely. How did you do it, Bert? Pediatricians, you need to stay away from them. They're very clever.
There must be a slide before that. Case 1.
Oh. Let's. Good.
Good.
I guess everyone saw the answer. Yeah? It's fine.
Yeah, let's start.
Good.
So there's still real cases. Next.
Subtle advertisement of Egypt.
No? It's not working?
Back meets forward. Yeah, not like this, yeah.
But it's not on the screen.
It's not on the screen.
Yeah, we know it's not on the screen.
Okay.
So let's try. We'll give it one shot. 62-year-old gentleman referred from a private hospital with anuria for 3 days following bilateral varicocelectomy. Serum creatinine was 9 milligrams per deciliter. Pre-renal etiology was excluded. Stable general condition. Ultrasound shows bilateral moderate hydronephrosis. I think I guess what's happened here. So,
from a varicocelectomy.
From a varicocelectomy, yeah, in a private hospital. Any ideas of what might have happened? I guess so. The ureters, probably. I don't know. I think probably it's laparoscopic.
It should have been lap, yeah.
Yeah.
Otherwise,
so what's the next step? Give more fluids, diuretics, refer to hemodialysis. Yeah, immediate surgical exploration. No, so this is like an MCQ. Fixation of bilateral nephrostomy tubes and delayed intervention. So how many days prior was it?
Couple of days.
Couple of days. Okay, so
3 days, I think. Okay, my friend here had a suggestion. What do you think?
No, 3 days of anuria, but I was asking.
He was asking if it was lap. For the purposes of this case, let's say it's lap.
Let's say it's lap, yeah.
Tell me what you think.
Ureteral ligator.
Ureteral ligations is. Did you ligate a ureter at all? Did you see? No?
It's,
What else?
Yeah. Could be. I mean, okay. So bilateral nephrostomy tubes were fixed. So that's the answer, I guess. Creatinine went down to 1.3 after 3 days drainage. Can we have the next? So, suprapubic exploration was performed. Right ureter, ureteroneocystostomy with psoas hitch, left ureter leak gregoire, anastomosis. So I guess the thing that happened was that must be strange, doing a laparoscopic varicocelectomy, instead of ligating the veins, they ligated the ureters. They're close by, but you have to be quite bad to do. Could be Palomo, yeah, but that's even worse, I guess, if you did the Palomo. So I think the gist of this case is that you have to treat, and if it's recent, you can do a reimplant, even with the psoas hitch here.
Could I ask a question for
Yeah,
this?
sure.
Would anyone investigate this patient differently? You do an ultrasound, you see bilateral hydronephrosis, you suspect a ureteric injury. CT scan is good. CT, contrast, non-contrast? Contrast, which phase do you want? Late, you want to see the collecting system. Who would do a retrograde? Does anyone do retrogrades? Yeah? Yeah? Very nice.
I think his creatinine was 9.
Yeah.
That's a good point.
Good.
The contrast, yeah. It's private. It's private sector.
Private,
no
private
pathology, I guess.
Retrograde ureterogram is reasonable.
The question is why the varicocelectomy was done on both sides. You do see bilateral varicoceles, but it's rare, yeah. I agree with you. But you make more money, probably, by doing 2 sides.
And next item about this case is they did a, what did they do? A Boari flap. What did they do?
They did the psoas hitch on the
hitch.
one side, and they did a leak gregoire extravesical reimplant on the other side. That's good.
Fair enough. Would you directly implant the ureter on the bladder without doing those? Let's say you've got lower ureter, clip on it, just open the clip and do a reanastomosis of the ureter. Can you do that? No. No, you wouldn't do that. Why wouldn't you do that? Bad vascularity at the lower end of the ureter and technically difficult to achieve. That's the take-home message also, I think. Lower ureter, not ureter anastomosis, always onto the ureteroneocystostomy, essentially.
So I guess the lower third of the ureter, you do a reimplant. Usually
Yes,
when
you
the
reimplant
lesion
it.
is in the lower third.
Yeah.
Good.
The rest you can put them together, back together somehow.
But it's not always possible to do an anti-reflux procedure, I must say, from my experience. Sometimes you have to just plug it in as good as you can, either with a Boari flap or a psoas hitch. So, good. That was the case 1. Let's see if we're as good at case 2 as. Okay, Zafar, you're the reader.
32-year-old pharmacist lady presented with right loin pain and fever 5 days following an operation of a disruptic ectopic pregnancy on the right fallopian tube. Okay, so they had an ultrasound with cystic collection at the right lumbar region. I guess we know where we're going to. Anyone?
There's a gynecologist involved, so get ready.
It's either the bladder or the ureter, isn't it? What else do we have anyhow too? Okay.
Next.
And that is interesting.
That's very interesting. So you have, this is what? Antigrade nephrostogram and an IVU. So on the left side, they've done an IVU, which we would probably do a CT for these days. And on the right, they put a nephrostomy tube and a nephrostogram. So I can't see ureter at all. And it seems that you have a dilated system or some leakage at that point. So on exploration, the ureter was completely gone up to the renal pelvis. What will the next step be? Will you auto-transplant the kidney? Would you do a nephrectomy, permanent nephrostomy, ileal replacement or an open pilostomy? That's a very good question, and I don't think there's a good answer to that. Zafar, what would you do?
I would be very scared. I think autotransplantation, it depends on your bit of your surgical experience. The anatomy, I would have done a CT scan. If the whole ileum has gone, ureter has gone, I would be inclined to do an ileal replacement.
Yeah.
I think
you must think there is no ureter at all.
That's what I understand. Yeah. Therefore, I would do a CT scan also.
An autotransplant could be a bit tricky.
There you go. But don't we want to do a scintigraphy to see if the kidney works?
I've gone with a CT.
But it's a good point. It's a good point.
What kind of scintigraphy do you want? Yeah, which one? You've got DMSA or MAC3? Both are good. But if you're looking for obstruction, you...
There, Zafar?
Yep.
You don't need the drainage, probably, so DMSA. Yeah.
I would consider trying to do a retrograde uretrography to see if there's some of the distal ureter left. Probably they cut it somewhere at the ovarian or the fallopian tube where they. So if there's a bit of distal ureter left, then I think you might consider an autotransplantation and implant the native right ureter on the transplanted kidney.
Very good argument. As I said, I've never done an autotransplantation, but you need some ureter. But I take the word of that there was no ureter left.
I have a hand here.
So my vote is still with putting some ileum in there.
I go with ileal replacement.
Okay.
I think that's what we're seeing here. The problem is if you want to do an ileal replacement, in this case, you would probably have to wait for a while. I mean, I would give her a nephrostomy for a period, and then we'll do the ileal replacement. Burke, go back. I think this is what he's trying to say here. This looks like an ileal ureter. It's a huge gap that they have replaced. So high complication rate, difficult operation, but as you can see, it's doable. And they've done a Buwari as well, as far as I can see. Questions? Anyone that would do anything else? I do a bit of transplantation. I can tell you an autotransplantation is not easy if you don't have a ureteric stump. It's difficult.
Next case.
Okay, so case 3. 12-year-old girl referred to the emergency room 8 hours following abdominal exploration for acute appendicitis. This is a lot of iatrogenic stuff we're going through here. On examination, there was a stent dribbling urine coming through a stab beside the McBurney's incision. So I guess she had a drain put in, and there was urine coming out. Let's see the next slide. Okay. One back. So this looks like an IVU, I guess.
There's a drain there.
There's a drain coming out.
Anyone wants to help us? We're at A&E now. Help us.
We know as little or probably less than you guys do. What do you think? What might have happened? Appendicitis. There's a hand over here.
Well, I think on the left picture looks like a CT. It looks like they might have stabbed through the urethra, and it's leaking urine. Yeah, and it's also because you can kind of follow the stab, I think, or I don't know if it's a drain.
That I think is a drain.
Yeah.
So we all agree it's a ureteric injury.
Looks like a ureteric injury, yeah. If it's possible, that's a good question. It's probably, I don't know. It's probably the same private doctor who did the varicocele. Yep, let's have the next picture. So there we see a bladder with contrast and the shadow of some contrast in the right pelvis. Probably. Next. So, what is this? Is that the appendix that hasn't been removed, I guess, on the top picture? So he probably did ureter excision, probably. And this is, I don't know what that image is.
They're trying to fix it now?
Could be. Is that the excised part or what?
They're trying to put an ileal segment
Oh,
probably in
okay,
between.
yeah. Oh, I thought it looked like something ex vivo, but this is...
No, kidney at the top, they're going to put a urine.
So, horrible case. Horrible case. Okay, so if you want to have an ileal replacement, you have to go to Mansoura in Egypt. They're good at it. It's really difficult. We do, I mean, a year, I think, in Denmark at my department, and it's really a difficult operation, especially if you have to bridge a long gap, because then you have to have multiple Monty channels. Yep.
But could I, since we're on another case, and we've done 3 ureters so far, does anyone know how to classify ureteric injury?
It's a good question.
AST principles. They're all traumas are from grade 1 to 5. It's like the TNM classification. T1 is localized disease, isn't it, in all tumors. AST has a similar principle. It's either a minor injury, which is always grade 1, and the worst is grade 5. Anything in between is somewhere there. So if you've got a small abrasion of the ureter, that's grade 1. If you've got a complete avulsion like that, it's going to be grade 5. And the distance between 2 complete cuts, if it's greater than 2 centimeters or not. These are the basics you need to just know, because if it's greater than 2 centimeters, you're going for a more aggressive reconstructive procedure. Correct me if I'm wrong.
That's correct.
So those are the main gist of the ureteric injury classification system. I don't think anyone expects you to know all the 5 steps, but for kidneys, they want you to know it.
Okay, case 4. A young man referred with fever and abdominal pain following left ureteroscopy in a private hospital. It's the same guy.
Surgeon.
Same guy.
Same surgeon.
For a simple stone in the left iliac ureter 3 days before presentation. So I guess we all know what's going to happen here. Next slide. Okay, so this is the left side. There's a huge leak, as far as I can see. Urinoma, yeah? And we skip to the surgical view where you can see probably, as I guess, the proximal stump of the ureter with some sort of J stent. And what's the next picture, please? Again.
They put some ileum there.
Ileum. It's good. It's good. So
Plenty of ileums.
this is a grade 5, you would say, wouldn't you, Zafar?
I mean,
absolutely.
You'll be unlucky if you see one.
So this is how he's doing his multiple ileal channels. So he divides the ileum, you open it antimesenterically, and then you tubularize and you put them together. And you might, the problem is, if you get them too close to each other, then you'll get them to bend. Okay, so you probably sometimes also have to take a segment a bit further away. But very impressive, very impressive. And the drainage looks good on the IVUs he's doing, or on the pylograms. Yeah, amazing. Yep. So let's have a case that's not a ureter.
At least something that we can all fix.
Can I just ask something?
Yeah, question?
Here on your right side. Here.
Yep.
I've never seen this surgery, but why would you make a Monty and use multiple Monties and not take just a piece of bowel of 20 centimeters?
Yeah, it's a good question. I think that, first of all, in order to coapt you're saying that you want to use a piece of bowel.
Yeah, I would.
It has peristalsis, okay? You have to make sure that you have it in the right way.
Yeah.
And other than that, from experience, it doesn't work. It's not like when you do an esophagus. So you have to stop the peristalsis, you have to do open the bowel and close it in the other connection. I mean, to be honest with you, I've thought about that as well, because it would be much, much easier. But the thing is, then how would you anastomose the ureter to the bowel? It could be difficult. But you could do like with an ileal conduit, you could put it probably. But I think it has to do with the size and the peristalsis.
Okay, thank you.
So, 48-year-old man who is known to suffer from some psychiatric disorders presented by his family 2 days after fixing a thick metallic ring around the proximal shaft of the penis. I just need to see what's what here. Okay. Bloody hell. Okay. This, I mean, in all urology departments, you've had a case, maybe not as severe as this, but something that reminds of it. So what did you do when you had this case?
We call the, not fire, but some, I don't know how to say it.
Technicians.
Technicians. We borrow some like stuff from them and we do it. It's like you are manufacturing or something.
The last one I saw, the metal was so hard, we used a jiggly saw and it didn't work. Yeah, and you have to cool the area down. You have to cool it down because it gets really, really hot. And the one, can I just have the pointer? It's here. So the one we did a couple of years ago, can you go back a slide? You have to cut the ring 2 places because it was so hard that you couldn't open it. So we had the fire department. They came in with a lot of their instrumentation. And the patient asked to be anesthetized. I would as well, because they came and we stood there cooling the region. So what did Professor Abul-Enain do? Does it say? No, the other way.
Sorry.
An ileal conduit or an ileal ureter. So, good. So it must be one of those cases like you also had. Zafir, you take the next one.
Cool. I don't know what we're going to do now. Let's go. I'm freaking out. Good. 52-year-old man. Okay. Road traffic accident. He was stable after being hypertensive for 1 hour. You check the initial blood pressure. Hemodynamically now became stable, I'm confused, with 2 units of blood, significant hematuria, which recovered within a few hours. This is a CT scan we see here. Can anyone grade that for us? What? Grade at least 4.
At least 4, yeah.
At least 4. Seems a bit more like a 5-ish.
Looks a bit shattered, yeah.
Yeah. So he's asking us, what should we do next?
So
well,
was he stable or what?
It currently sounds to be stable after 2 units of blood transfusion and hematuria recovered. Would anyone send this patient home? No. Okay. I think I understand what he's trying to ask, yes. That's in our EAU guidelines also. Once you have severe grade 4 or 5 kidney injury, within 24 to 48 hours, if they're stable, you need a repeat CT scan. I'm just remembering out of my mind.
It's true, yep.
But however, if they become unstable during that period of monitoring them, you need to repeat the CT scan immediately or take them to theatre, depending on what you're dealing with. A week later, this is a CT scan of, well, you can see now it's as if it's a duplex kidney, upper moiety, lower moiety. Still hospitalized for a week, but now he's having recurrent episodes of fever. Urine is clear, HB has become, so the patient stopped bleeding, but now he's having fever. Okay, what would you like to do? Is the question. Does anyone want to send him home with fever? No. Yeah, let's eliminate that.
So what are we thinking?
It's somehow infected. Are we thinking there's urine leaking there in that image? Do you think there's urine going out? Probably I would have thought so. The collecting system is opening into the hematoma. Can you see that top upper corner there? The upper pole? Am I right there?
Excuse me?
Do you agree with that?
I think so.
I think there is
because on the
urine.
initial image, it doesn't look as if there's that much leakage, but there must be into the hematoma.
Yes,
So
yes.
there must be either an abscess or you have some leakage. I would drain this guy. I would with a double J, but it's difficult, I must say.
So
CT after
they
2
keep
weeks.
doing CTs and probably giving him antibiotics, and the patient goes home with a 3 months then. So probably the patient picked up with antibiotics and conservative management, and he's trying to ask us, what would you like to do on month 3 after you manage a kidney trauma patient? EAU guidelines has the answer to this question. What do you think you would do? What's the long-term complications of kidney trauma? AV malformations, pseudoaneurysms, hypertension. Does anyone know the special name for hypertension after perirenal hematomas? Page kidney. What's goblet kidney?
What's vascular? No?
Tell us what page kidney is.
I think it's the pressure outside the kidney that compresses the kidney and decreases the kidney function by decreased filtration.
And goblet?
I think it's intravascular.
Correct.
Excellent.
So what did they do in 3 months? IVU. I would have said nowadays we would go for CT scans. We don't really use, I don't know if anyone
So I guess this is a question. Is it A, B, C, D, or E? Don't you think?
Yes.
So let's, the next slide.
Okay, that was the case. Would you mind just going back, please? Does anyone do IVUs still? It's not wrong, but...
Has everyone seen an IVU? Okay,
Yeah.
a couple of old people here.
They entered urology.
Many years ago, they stopped. But yeah, they're still done.
CT at 3 months is reasonable, and you can also argue to do a nuclear DMSA scan in these
What
patients.
would your reasoning be for a CT in 3 months?
There's a couple of reasons. One, medical legally, you want to protect yourself. You want to see that that kidney is still alive
But
after...
you could do a nuclear scan for that.
You do a DMSA scan for that. You can do either or. We do DMSAs.
We do DMSA 3
Yeah.
months and blood
Yeah.
pressure control. We don't do CTs.
You don't do CTs.
Unless it's a totally shattered kidney and you want to know how things have
So
developed.
this case, I'm not sure what's going on at the upper pole here.
No.
That's why.
Exactly. All may be required. That's what it says. Okay. So we'll take one more case. Can you go in the middle of the presentation?
Give us something with a ileal. Something.
Ileal conduit.
Something. Okay, perineal amputations, genital trauma. Okay.
Let's take this one.
Should I read it?
Yeah, read it.
50-year-old lady presents with total urinary incontinence for 10 years. Okay? So it's both stress, mixed, so it's just leaking, that's what I understand. She had history of 6 times surgical operative interventions. Do we all know where this is going to? Yeah? Maybe fistula? Something
Fistula
else?
is being said here.
Yeah, we've got fistula. She had a hysterectomy, sacrocolpopexy. Fecal fistula probably means a rectal fistula. Trauma to the colon, and ended up with a colostomy. 2 attempts of repair of the fistula. Okay? Okay, they're going to repair a fistula. Fine.
The site of the left colostomy was shifted from the left to the right, subhepatic colostomy. Big abdominal defect was repaired by mesh, so it's going to be messy, this.
Glorious surgery.
Yeah. Okay, so.
Fine.
There's not much trauma.
Don't know
here.
what the learning point would be for, but when you hear such a history, yes, the first thing you should think of is either fistula or it could be the ureter. Most common is vesicovaginal fistulas. Again, is this a case or what? What is this?
I don't think we'll be able to manage this. So.
Let's carry on. Let's carry on something we can. Okay.
Thank you.
Thank you.
You've deserved an early break. Thank you for today. Questions? No. Have a nice day, and
have a nice day.
tomorrow I hope you have a nice day. What do you have tomorrow? Andrology, excellent. Thank you. Thank you for
Show
today.
them the penile amputations, ask them, not us. Yeah.